Good morning, our lovely listeners of Sun FM Radio and TV. I'm glad that you could join us on the latest edition of the Health Talk, which comes your way every Saturday. So today we are discussing something that is of keen interest, I should say, because it involves us taking care of the chronically ill. And we are discussing palliative care, understanding palliative care, the dignity, comfort, and compassion. How do we take care of patients that are in this particular condition? So to help me understand this, I have two ladies, or women I should call them, because they are my mothers. Matron Betty Galufu Njunju, let's hope I pronounce that one correctly. She is actually the senior nursing officer, Ndora Teaching Hospital. And then Matron Prosperina Zimba, who is also senior nursing officer from the same institution. And your host, my name is Lamek Zulu, also known as Folegs. So let me welcome my guests. Madam Njunju, how are you doing?
I'm fine, thank you. And how are you too?
Great, I'm great. I'm glad that you could make it and join us today. Madam Zimba, how are you doing today?
I'm fine, thank you. And how are you?
I'm fine. And hopefully our listeners are glued just to, listen to you. Give us that advice that they need for them to take care of the patients. So let's define this. What is palliative care in simple terms?
Thank you so much. Palliative care is a scientific approach, or it's a scientific way that we provide to the patients and their relatives, especially the patients that are facing life-threatening illness. And we do this through prevention, relief of suffering, by means of early identification and impeccable assessment. And we also do the treatment of the pain and other problems like physical, psychosocial, and spiritual. So in those terms, that is palliative care.
That involves a lot.
It does. Thank you.
Yeah, it involves a lot. Okay, so so now let's look at how palliative care is different from other forms of treatment. Madam Zimba.
Thank you so much. Thank you for this opportunity that you've given me. So palliative care for sure is very different from the curative treatment. I'll start firstly. Palliative care is looking at the conditions that are life-threatening, that are life-limiting, while curative is looking at conditions that are just there to be cured, and that's the end. So you find that palliative care, we dwell most on our clients, our patients, from the time of admission up to the end of life. So palliative care does not just limit you just to see them and end there, but you have to be with them up to the end of life. While curative looks at just to cure. So I'll give an example. When a patient comes with cancer, maybe needs amputation, so you find that with the curative, they'll just go into amputating and it will end there. But with palliative care, we'll come in and look at how is the patient accepting the condition, how is the patient being relieved of pain, how is the family, what is the social life of this family, what are the plans thereafter. So you find that in palliative care, we also work in as a multidisciplinary team, while curative is where one is specialized and just concentrate on that condition alone. So those are some of the differences that we have in palliative care and curative.
So at some point you form a bond with this patient.
Oh yes.
They become like your relative.
Yes, they become part of your life, part of your family, and that's why it becomes even easier when one loses a family. You are able to continue with a life with them.
Okay.
Yes.
So now let's talk about the objectives of this palliative care. Madam Njunju, what are we trying to achieve?
So in palliative care, there are different forms of pain. So our main aim is to relieve the pain We want to control the symptoms that are presenting with the patient. Then we want to prevent the side effects and the complications. And we also want to maintain the best quality of life possible.
So at what stage do these patients introduced to this journey?
This, we start as soon as the diagnosis is made. And for lack of better term, we also, immediately the patient is given to us, is referred to us, especially patients with heart failure, cancers. So we can come in at any stage when the service is needed, when the care is needed. So we can approach and talk to those people at any stage we are available.
Okay. So now how do healthcare professionals determine if a patient needs palliative care? Madam Zimba.
Okay, thank you so much for that question. The healthcare, when a patient comes into contact with the healthcare, what they're supposed to do is to get a detailed history of that patient. Okay, detailed history of that patient so that they know the patient very well, how the condition started and how the patient is faring. Then also in part of the history, we add the physical history, which is, we do the physical assessment of a patient. That's physical examination from head to toe, because there are some conditions which a patient may hide. I'll give an example. A client will come with backache, not knowing that what has caused that backache is because of a breast cancer which has already started and no one has seen it. Okay, so you find that some may conceal that. They don't want to show it. They want to stand to say, I've come here with a backache. So how do we do it as health professionals? So by history taking. In history taking on palliative care patients, what we do is you get physical, you do physical examination, you get the social history, you get the psychological history, you get the spiritual part of it, because we believe that for you to being, you need to, you have all these needs that are supposed to be whole at a certain point.
Yes.
When one of it is not okay, then you have a problem, then you have a palliative care. So for a professional to really find this patient, for sure you need to do all these investigations, including investigation for you to come up with a diagnosis, because you cannot say this is cancer when you have not done the physical examination, you have not seen it, you have not done the investigations, so you find that you give a wrong diagnosis.
Okay, now how do you initiate this conversation? In case I come to the hospital, na isa mibe patawe ile karipa ninu makanshi ni fimbi.
That is very possible and it's very interesting. So that's why we need to take a keen interest in you. Yes, so we need to take keen interest in you. So we'll ask questions and I will look at you. The expression, if you're hiding something, you might be saying, I've got a backache.
Got a STI.
Yes. Meanwhile, your gestures and the clues, your body language will show. Because I have to really be patient with you. We'll ask certain questions and then we have to assess. You know, we say that a patient is complete when they are mental status, physically they are okay, spiritually they are okay, emotionally they are okay, financially. So when we take the history of the patient and the family, in our background, we are also assessing, is this patient economically sound?
Okay.
Are they able to cope with the problems that are coming in? How is the family going to survive? Especially if we admit a breadwinner, it really becomes a problem, because at one moment he has to stop providing for the family because this disease will take over. If they were working, they will have to stop. It is worse with our people not in permanent jobs, like people working maybe for
private institutions where you are paid according to how many hours you work.
Yes. And you know, immediately you just stay away from work maybe for 2 days. By the time you get back, you find that they are replaced. we are talking about families also being involved here. For example, if it's your father who is sick and you the child, you are the one who is working, you have to stay away from work to take care of your father. Is your job secured? So you find that this patient, together with the family, will not be at ease because their income source has been disturbed. And this becomes a problem. How are they going to live, and who's going to take care of them? Well, still, if they are not living in their own home, they are staying in a rented house, because sooner or later they will be expecting a knock on their door to say, we want our money for rent.
Rentals, yes.
Yeah. So when it comes to physical pain, at least physical pain, when they come to the hospital, we are going to treat them. We're going to give them the painkillers. It's going to relieve the pain. That part will be done. So when it comes also to psycho problem, the psyche is also affected, because this person will be weighed down by the disease.
Yes.
And so does it to the relatives. Whoever is around, whoever is taking
will also
care,
be affected.
Yes. So we want to take them holistically. Yes. So that we move with them.
Okay.
Yes.
That's a lot. That's a lot of work.
It
You
is.
wanted to add?
Yes, I want to add on. Yes, like when you want to start a conversation with this client or with this family, first as a health personnel, you're supposed to acknowledge that there is this problem.
Okay.
And then you prepare the patient to say, okay, I know I'm going to tell you this. I know it's hard, but this is the situation you are in. How are we going to care for you? So you sit down as palliative care and the family and the patient. You plan the care for that patient together with knowledge of the patient. So we don't just come, okay, we are palliative care now, from today start doing this, start doing that. No. We sit down, you break the news, you tell them who you are, you tell them what they are going through, you understand the situation, you make them understand also the situation that we, in this case, this is palliative care, it's not the end of the road, and there's still life to live on. So you sit down with them and plan the care together, and you find that when they understand the situation, the condition, you find that life becomes easier for you as a health worker and for the patient and the family. So palliative care really is a must practice thing. Yes.
Okay. So now, who qualifies for this care that we're talking about?
So as we said in our definition, we've got so many conditions that are life-limiting and life-threatening. So anyone who has a chronic condition.
For example, stroke.
Yes. And you know stroke. Have you ever come across a stroke patient?
Yes, I have.
You've nursed
No, not nursing, but,
or you
but
have just witnessed.
I've seen them from a distance. So I can actually have an idea of their struggles.
Yeah. So imagine an able-bodied person lying there. If he was a mechanic, he's lying there, all the tools. So meaning the income has been affected. Now coming to the body physically, you know, somebody was able to move, can't move. You have someone has to think that it's time to bath you, it's time to tend you, it's time to dress you, it's time to feed you. So both the patient and the carer.
The caregiver.
Yes.
They get tired.
They get tired. They get emotion. So you really have to, they really need an encouragement for somebody who's going to encourage them to go through this journey. We are not going really to put hope or reduce, but just helping them cope with the available resources.
So maybe let me find out. You follow them at their home?
No.
Or they have to come to the institution?
They come to the institution because ours, yes, we offer palliative care in patients. So we've got boundaries.
Oh, okay.
Yeah. Very few occasions that we followed one at home, just to encourage them to assess how they can take care of the patient in the house, just to teach them and to look out for certain other symptoms that can be threatening, so that they are able to react as quickly as possible should that symptom happen to occur in that patient. Yes.
Now, are we just focusing on those that are terminally ill, or even those that are not terminally ill can receive palliative care?
No, we focus on everyone, anyone who's been diagnosed with the life-threatening. For example, at least nowadays we've seen people now coming to terms with HIV. You know, those days when they diagnosed you to have HIV, people thought that was it, and we
saw a death sentence.
Yes, we saw people taking their lives. We saw people withdrawing. But when one is diagnosed with that life-threatening, we have to tell them what it is and what they're supposed to do in order to prolong their life. And we've seen so many people living happily. And nowadays, now we have cancers on the board. Cancer is really taken a strong, what can I say, a strong
Most
part.
people are affected.
Yes, they are affected. They also need talking to them, reassuring them to say they still have a life. We can still add what it is, prosperity, adding their life, their days to their life. Even if they have a short time, but they can still live a quality life before actually.
Okay, I'm trying to imagine. Here's a doctor tells this patient, you have 6 months. So, so your role is to make them enjoy their 6 months.
Yes, to enjoy it without pain, at least with assurance
that there is light at the end of the tunnel.
Yes.
You must be very prayerful. Okay, so can children also receive this care?
Yes.
And at what age?
Children are a special population.
Yes.
Yes. They also need to be taken care of. I'll give you an example. When a family is undergoing or they are nursing a breadwinner in the family, a very significant person, or when there's a funeral, children in their care, you know, they are left out in the corner. So we really need to pay attention to them, because even them are undergoing the grieving, the suffering process, and it's very difficult since they cannot express themselves. We really need to understand and involve them in the care. So once in a while, we need to involve them. Maybe we can even give them a piece of paper. You know, children can express themselves by maybe form of drawing. Yeah,
writing.
you need to look at it and understand what are they trying to, what message are they sending?
Are they sending emotionally?
Yes, emotionally. Yes, maybe my friend can also look at the elderly also.
Okay, thank you so much. So I can still add on the children part.
Yes.
To say yes, children also need palliative care, and mostly we depend on the parents' care as well. Of course, for us to assess pain, we won't assess it the way we assess in elderly. With the children, it's a different one. So for sure, children need palliative care. When you offer to a child, you also offer to the mother, because palliative care covers a patient and the family at large.
Yes, sir.
So if you are able to give information to the family, then they'll be able to carry on with whatever discussion you have with them. So children need palliative care. Children don't have to be in pain, because there is the pain relief medication, they are available for the children. Okay?
Now, for children, medicine is available. Okay.
Yes.
Now, I know that Ndola Teaching Hospital is a...
Adults.
Yeah, it's for adults, and it's a big institution. So when you have a child, what do you do?
Okay, thank you. So when you have a child, you go to Arthur Davidson Children's Hospital. They also offer palliative care there.
Oh, okay.
Yes, we have nurses. We have nurses all over. We have people who are trained. This time, palliative care is offered in universities, nursing schools. Palliative care is there. So this cannot be, it can't make somebody fail to provide palliative care to a child. So whatever, even in the clinics, we have nurses who have been oriented in palliative care, of which they can as well offer.
Okay.
Yes.
So now, here's an adult who comes to Ndora Teaching Hospital and they want to know where the unit is located. Where exactly are they supposed to go?
Okay, currently, we do not have a unit per se, but we are reachable. Like myself, I'm found on the first floor, and the doctors would reach us by way of writing a consultation. Or we can even talk over the phone to say, can you see this family or this patient in this ward? Then you happen to go there and assess.
Okay. And then what type of services are offered at NTH
So
in palliative care?
So at NTH we offer almost everything.
Okay.
It's an inpatient hospital. So we offer palliative care as inpatient, as outpatient. I think that is what we offer. We do counseling. Most of the people, like those who come in OPD, those that have been to OPD, they've seen me walk around that side. I offer counseling to most patients. I'll give an example that those that I pick on the queue or those that I meet, the diabetics, the hypertensives, I sit down with them one-on-one, we talk. That is how I offer my palliative care. And then for the hospital, for the public, when you want to find us, I'm in OPD. I'm found in OPD. When you come, just ask for Matron Zimba. They will locate me for you.
Oh, okay.
Yes.
Okay. Is there any cost that comes with this care? Could it be Vamara?
So there's literally no cost. But when you come, it's either you come under NIMA, you'd have paid under NIMA, or you came under standard, you'd have paid. So as we offer, it's a service that we are offering. And anyone and everyone is free to come and consult us.
Okay. At this point, let's open the phone lines, Oliver. Let's see if our viewers and listeners have any questions, comments, contribution, or any form of clarification before we move on. So +260-212-617140. That's the number that you can use in case you have any clarification or just any question, or maybe you need somebody to talk to. You, I mean, they've already put it on record. They are counselors. They are willing to assist you through your problem. So you can actually call and just ask that question, or maybe you might share your problem. Maybe before we even continue, let me ask you this. This one is a bit personal for both of you. Which one has been your most critical time when you are offering your services to this particular patient? Because we have established that you create a bond with with your patients and the people around them. Madam Zimba, I'll begin with you. Which one has been your most critical? Okay, but share with us.
Yeah. So the most critical time is when you have not known much of that patient, and the patient sleeps out and dies. So how do you break the news to the family? It's really hard to break the news to the family when you have not known much of that patient. And you feel like you'd have done better. Maybe at that time when they called me, I would have gone. Maybe I would have done this. So really, breaking bad news to the family is that is very difficult and so touching to us as well. We go home with burdens. We go home with burdens to say, oh no, breaking bad news is not something that is easy. Yes. So the other part where I really feel like, this family I wish I did, is when the children were not involved in the beginning to the care of their mother or care of their relative. And now you are made to tell them to say your mother or your father has died. That one is not good.
Okay. Madam Njonjo?
Yes.
Yours?
Mine is when there have to be some decisions to be made. You know, as palliative care, we advocate and we also help, we facilitate in the decision making of the family towards the care of the patient.
Yes.
You've heard nowadays people are flocking abroad to go and seek medical
help.
care,
Yes.
and also to undergo very, very expensive diagnostic procedures. So we have to be like strong enough and truth-telling. You know, in our culture, we do not talk about these chronic illnesses and death because it's a myth. So it's high time we started preparing our families, our children, to say there's life even after death. And walking through this journey is really difficult. So as a palliative care nurse, you know, you come across somebody who would want to sell out all the properties they have in order to obtain or to get this treatment at the expense of the children or the families that will
remain behind. Yes.
So the moment we start engaging them to communication, they will understand. Even the patient will understand to say, I only have a few days or moments to live on earth. And you have to prepare them really on how they are going to live their loved ones. How are they going to continue if at all they were in business? Who is going to own what? And I cannot do these things at this moment now because we're multidisciplinary. We have to now engage if at all we need any legal coming in so that those children or that family is protected.
So, like, in short, you help them write a will in advance.
Yes.
Obviously, if,
yes.
when you have a
So
lawyer present.
Yes. So that one has to be done when both parties have understood what you are talking about.
Both the wife and the
yes,
husband.
and the family, yes. So that when that happens, no one will come to you crying. At least they will feel helped by making that professional or informed judgment.
Yes.
Yes, so to say. So this is very difficult because it involves some sparks. We're not supposed to go there deeply. So we just introduce it to them.
So that it's like you open their mind.
Yes.
In case
So we can approach this in this way. Imagine.
Yeah, because no, I'm imagining somebody say you are telling them this. So or
it's you feel so good when somebody say, now that I have this condition and I'm about to die, I want my children to do this, particularly this one, my wife to do this, and all these things. My parents should have this. You know, you feel relieved because that will help a family to pull through. You find that even in their grief, when one dies, at least they will mourn properly, knowing very well that they will take other steps in a positive way.
Okay. Now, in line with that, do you offer any bereavement services?
Very difficult. So this will depend on the communication or the association that we had with the patient. Sometimes we are called upon because we just merely ours is just to facilitate, and as quickly as possible we want to identify an expert. Yeah. So if it is legal issues, at least quickly we'll refer them.
You refer them to a lawyer.
Yes. And then if it is something to do with the spiritual, quickly we will involve maybe a pastor or a clergy to come in. We just want to facilitate, or as you rightly put it, to open up one's mind. Yes.
Now, I know that we live in a society that has different cultures, and there are different perceptions about what we've discussed. I'm sure you've come across people that are so much inclined to a papa. So you tell them, those people are very difficult to convince. So how do you handle such? You tell them, okay, you have this condition and you need this medical attention. But they'll tell you, first in past. So I'm sure you've come across such encounters. Madam Zimba, how have you dealt with such people?
That is a very interesting topic. Of course, we've said palliative care, we also have a spiritual part.
Yes.
So when somebody has said or mentioned like he wants to see her man of God or his man of God, we give them that opportunity because that is a spiritual belief. They believe that when they talk to this, whatever decision he's going to give is going to work for them. That is their belief. So we don't trample upon their beliefs, no. We let them be with their belief. But of course, we give also our side of view so that they have both sides. Mind you, we said to look at psychological, social, spiritual, and physical. So that is the spiritual part of it. Because some believe if the man of God has not said anything, then it means they are outside the coverage. So they would rather be wanting to be inside the coverage of the man of God, that he's aware of what is happening. So I think that's the whole essence of wanting to ask, is to make him aware that, okay, my child of God, this is what he's going through in his life.
Okay, nice. So in terms of, do you offer any educational services? Do you take time to walk into schools? Do you apart from what we are doing here, this is also awareness and sensitization. So what other programs do you have? Okay. Just to make sure that communities are engaged.
Okay, so like you have already said, I think you have already answered on behalf. So yes, we do what we say, information, education, and communication to our patients, of course, as we meet them one-on-one. Then we also give education to the nursing schools when we are called upon. So there are some that we give, like the ones we had last time where the HIV/AIDS nurse practitioners, we were given some hours to teach palliative care, of which it's really an advantage or good for us because that's the platform that we can educate some community. And then also coming here, I hope this is not the last time.
I know the door is still open.
Not the last time. So I hope we are going to be called again to come on this also to give the information to the community. Then also sometimes we are given chances in our respective place of worship to talk about palliative care, to talk about health talks in churches. So this is not the only place that we give.
Nice. Now let's talk about cultural perception.
Yes.
We know we come from different cultures. What are some of the things that you've encountered that people perceive in relation to palliative care?
So culturally, sometimes palliative care is perceived in a negative way. Like we've got some drugs that we give to relieve pain.
Yes.
So some people really perceive them that immediately they start taking these drugs, they'll be
dying slowly.
Yeah, they'll be dying slowly, or they'll be addicted,
okay.
Or immediately they say you need to see the palliative care givers. One feels like, no, that's it. That's a death sentence to me. They'll think that is a death sentence. So that is how sometimes the culture would affect this palliative care. Yes. So
maybe I can come in.
Yes, you can come in.
So I can come in also to say, sometimes even from our fellow health workers, they will name a patient to say that one is for palliative care, of which that is not supposed to be the case. So it's like you get labeled, no, that one is for palliative care, like as if they'll do nothing, but what is there is just to help the patient understand. So those are some of the challenges or some of the beliefs that people have, that when you are a palliative care patient, you are deemed to die, or you are in the process of dying. So even when we give the painkiller, which we give, I'll give an example, morphine. Others would even say, don't give morphine because this morphine is killing them slowly, but that's not the case. Or they'll say, don't give morphine because morphine is addictive, but that's not the case. Our patients don't get addicted to morphine.
I'm glad that you've clarified that. Now, do we have any testimonies of people that have survived after this palliative care?
There are so many.
At least share at least one or two so that someone who's listening can have hope.
Yes.
So that we kill off these myths.
Yes. We've dealt with so many in the hospital and also in the community. I'm really taking care of one person right now in my community where I come from. And I've developed a bond. They can wake me up at any time and help bring the patient to the hospital, or just being with them, just help whatever symptom that they are going through. I'll be able to help. And they are now free to come to me at any time, even the patient. And when I haven't seen her for some days, she will even request, but where is she? Why is she not coming? Yes. And so we've helped them that way. And we've also helped, yes, we've also helped even when death comes, the grieving period, even when the funeral is over. We are still called to the family to go and talk to them just to see how they are coping.
Yes,
and
to counsel the family.
Yes, and their doors are open. They are open to listen to any counsel. They become just a part and parcel of you. Yes, until there's that closure finally.
This one is not a job. This one is a calling.
So maybe I can. You can come in of one of the testimonies that I've had.
Yes.
Whereby I was introduced to this patient. We nursed the patient together with the family. Like she has said, you are called at any time. They will want to ask you, and whatever you tell them, they will believe you because you have been with them from the beginning. So at a time when their patient died, thank God I was within the hospital. So they called me, come and see, the condition has changed. I was with them. Even when death occurred, they were not that bitter. Instead of going out crying, they were busy thanking me. So I'm like, why are they thanking me? Because they've lost. So that is one of the testimonies that I can give, that even in death, they'll still come back and say thank you. Why? Because you were with them, you prepared them, they knew that, okay, time will come as such that this patient will die. So such are some of the testimonies that we have.
Okay. As we come to the conclusion of our topic, I don't know, maybe my listeners are emotional today. So what would be your last message? What do you want people to take home from this conversation? I'll begin with you, Madam Betty.
Yes, we thank you for giving us this opportunity to come and educate the massive. So palliative care is simply there to improve one's quality for both patients and also the relatives. So when you undergo palliative care, you'll be able to make sound decisions and sound judgment as we go through the journey of missing our beloved ones. And I've learned that we have learned to work with other partners like the churches. Like last week, we had the Catholic Church who came to donate resources to our chronically ill patients, especially those diagnosed with cancer. And that was very good. I could see that was an emotional part. So the thing that I'm trying to be there is that we are happy that our partners, our churches are able to come and help us. We are not the only one on the journey. Yes.
Okay, Madam Zimba, your closing remarks.
Yes.
What do you want our people watching us on TV and listening to us on radio to take home?
Yes, so all those that are listening, I know you've been coming to OPD looking for Dr. Msangu. Everyone knows that name. So when you look for Dr. Msangu, look for Matron Zimba, you are going to find her and she'll help you in whatever way you want in palliative care. Then lastly, I think I would appreciate our administration at NTH, our SMS and everyone else in management for giving us this opportunity to come out in in public to talk about palliative care, which most of the people, most of the health workers don't like it because of the involvement that it takes for one. Otherwise, we say thank you, our listeners, and thank you, our viewers.
Okay, nice. Okay, so a heartfelt thank you to you, Madam Betty, and Madam Zimba, for coming. We are grateful that you found time just to come and educate us on this. I have personally have learned a lot. I didn't know some of these things. That's why I'm saying this is a calling. This one is not. It's not something you learn in nursing school. Yeah? So for our viewers, I encourage you to always stay healthy. Remember that palliative care is not a death sentence. When you are diagnosed with a disease that needs such attention, please make sure that you follow the instructions and always keep healthy. I always remind you that a healthy nation is a wealthy nation. So just for the goodness of Zambia, make sure that you're up and running and you do the right thing. So on behalf of my producer, Oliver Kauma, my name is Lamek Zulu, professionally known as Four Legs. This is where we come to the end of this edition of Health Talk. Please join me next Saturday with another informative edition. We are out. Bye-bye.
Thank you.
So 1 hour is done.